Dr. Shovik, we are live. You can start.
Good evening and welcome to the expert crosstalk on empagliflozin, multi-mechanisms, multi-indications and multi-benefits. As we already knew that ESC 2020 was memorable with the path-breaking clinical data presented from multiple global trials. This program is designed with the objective of dialogue between two different specialties, that is cardiology and endocrinology, which will bring upon two different ways to address the complexities of the clinical cases in heart failure. So according to EMPA-REG trial, does SGLT2 inhibitor may be considered as the important drug for HFrEF? To get the answer, let me introduce today's speakers. Today's speakers are Dr. Dipak, Ranjan, Dr. Ipsita, Mishra. And I'm your moderator, Dr. Shavik. Dr. Ipsita is an assistant professor, Department of Endocrinology, SCB Medical College, Cuttack. Ma'am has got publications in various national and international journals and has received several awards till date. I welcome Dr. Mishra in this expert web talk.
Thank you, Dr.
Thank you, ma'am. Our next speaker is Dr. Dipak Ranjan Das. Dr. Dipak is an assistant professor in Institute of Cardiovascular Sciences, SCB Medical College and Hospital, Cuttack. And presently, Dr. Dipak is working as a faculty in Cardiology Department of SCB Medical College, Cuttack, and reviewer of international guidelines on hypertension and Indian Heart Journal, and also has many publications in many national journals and also has a teaching experience of more than 15 years. I welcome Dr. Dipak in this expert web talk, and I'm handing over the session to Dr. Ipsita to start with her presentation. Thank you.
Yes, thank you, Dr. Shovik, once again. So I'm going to quickly start sharing my screen.
Yes, ma'am.
All right. So before starting on, I would like to thank Lupin for giving me this opportunity and organizing this web presentation. So what we are going to talk is about Empagliflozin, the new drug which is now found with multiple benefits on multiple systems. So we are going to discuss about the multi-mechanisms, the multi-indications and the multi-benefits. And we will be discussing everything from the endocrine perspective and from the perspective of the cardiologist. So I'm going to deal with initially with the endocrinology perspectives of this drug. Overview of my presentation will be is like, why do we South Asians, we vary in terms of our metabolic parameters in comparison to the other population, especially the Western world? And why does the use of SGLT2 inhibitors will be more beneficial probably in long term to our group of population? The current role of SGLT2 inhibitors in management of T2DM. I'll be only discussing one single landmark trial, though following EMPA-REG, multiple other trials have come up with Empagliflozin, which will be discussed by Dr. Dipak sir. A brief review about EMPA versus other SGLT2 inhibitors and what do we learn from this. Now, the South Asian ethnicity and the cardio-renal metabolic risk in T2DM is different in comparison to the others. Now, why is it so? Because basically, we Asians, Indians, we carry this thrifty genotype phenotype occurrence, the genetic risk. So even at a lower BMI, even at a lower body weight in comparison to other populations, we have increased content of the abdominal fat, which is called the yo-yo paradox, which predisposes us to more of insulin resistance even at a lower BMI and a lower weight. So ultimately, there is an alteration at the level of the beta cells. When there is insulin resistance, the beta cells are challenged. And of course, apart from the genetic risk that we carry in the later years, in the last few years, there has been urbanization, migration, alterations in our dietary food pattern, like intake of large amount of carbohydrates, which leads to a postprandial hypoglycemia, and physical inactivity. Though Indians, they work, but the proper amount of physical activity which is needed to maintain the metabolic parameters are probably not achieved. So multiple biologic factors and lifestyle factors exist in our population, which ultimately leads to a different kind of phenotypic manifestations of T2DM. It's not just hyperglycemia per se, but multiple other problems which set in our population who are T2DM, who become T2DM later on. So we need a drug which will rather try to modulate almost all the components of the metabolic syndrome, the various risk factors which will lead to the onset of many complications in T2DM patients apart from the glycemic parameters. So of late from multiple CVOTs, it has been found that this SGLT2 group of drugs, they benefit us by modulating a large number of factors which ultimately lead to an increased CV outcome. So what are they? Now, apart from the glycemic parameters, by decreasing the glucose levels, SGLT2 inhibitors have been found to decrease weight, rather cause a decrement in the visceral adiposity, which is a larger determinant of increased insulin resistance. By its pleiotropic effects, it has been found to decrease the oxidative stress and the anti-inflammatory state. It causes improvement in your lipid parameters. It causes decrement in the serum uric acid. It causes decrement in the level of albumin excretion in the kidneys, causes a decrement in the blood pressure. Apart from the blood pressure, the arterial stiffness, which ultimately leads to altered in the blood pressure parameters, which is an important risk factor per se to determine the CV outcomes in T2DM patients, that is modified. And of course, the sympathetic nervous system activity. Now, this has come up in later, newer studies where it has been found that SGLT2 inhibitors do modulate the SNS activity, which not only has a bearing on the cardiac system, but also on the glycemic parameters. So we need a drug which will probably target at all these levels, because now this is the data why it is important to target all of these. Now, apart from the fact that only 8.7% of the Indian population have got diabetes currently, which by 2035, 2050 is going to amount to around rather 15 to 20%, which is projected from right from now. So when we draw this Venn diagram, where we are able to see the level of overlap of T2DM with other multiple risks, which ultimately determine the occurrence of mortality and motility in these patients. So 32% of the patients with T2DM in Indian studies, this is the data from the Indian studies, have been found to have coronary artery disease. Now, 12 to 45% of patients with T2DM have heart failure. 60% of patients with heart failure and T2DM have got chronic kidney disease. Around 30 to 40% of patients per se with heart failure have CKD. Now, this is kept apart from the T2DM fact. So 30 to 45%, that is a contribution of heart failure and CKD minus the glycemic parameters, data from the Indian population. And 20 to 45% of patients with T2DM have got chronic kidney disease. So when we use the Venn diagram, the amount of accountability of these multiple comorbidities is so high. Definitely, we want to use a drug which is going to target each of these complications, I would rather like to say. Now, SGLT2 inhibitors, theoretically, they have been found to have multiple mechanisms of actions, which I'll be taking up in the next slide. So this is just an overview. So from the multiple mechanisms, what happens is there is improvement in your cardiac function, there is alteration in your weight, there is improvement in the renal parameters, there is an improvement in the left ventricular mass, which determines the occurrence of cardiac complications in long-standing diabetics, and there is a decrement in blood pressure. Now, how this occurs? So the proposed mechanisms are natriuresis, glycosuria, and a combination of natriuresis plus glycosuria. So glycosuria per se, it will cause to improvement in the glycemic parameters and a reduction in the body weight. And natriuresis plus glycosuria per se will cause a decrement in the proximal solute reabsorption, improvement in the energy requirements at the level of the renal tubules, more of renal tubules, and a decrement in the hypoxia in the kidney. So here, not only the glycemic parameter is taken care of, but also the renal problems are also taken care of by the use of SGLT2 inhibitors. Now, natriuresis, which occurs by the tubuloglomerular feedback alterations and contraction leading to a contraction of plasma volume, causes multiple mechanisms which leads to cardiac benefits. Now, how this occurs? There is a decrement in blood pressure, there is improvement in your heart failure outcomes, So, and the proposed mechanisms are by the activity, there is a decrement in the activity of the sodium hydrogen ion exchanger, increase in the erythropoietin synthesis leading to increased hematocrit, giving a cardiac benefit, and of course decrease in the markers of inflammation and improvement in the oxidative stress. So this is basically a theoretical slide where the multiple mechanisms of SGLT2 inhibitors, how they are being effective is explained. So, diabetic nephron in a diabetic patient, where basically the SGLT2 inhibitors act at the levels of the proximal convoluted tubules and the S1 and the S3 segments, leading to glycosuria. So, when a diabetic patient, a diabetic nephron is not being given any SGLT2 inhibitors, what happens is there is an increased delivery of both the sodium chloride and the glucose. And we all know from our basics of physiology that there are reabsorption, simultaneously there is a reabsorption of both the sodium and the glucose molecules by the SGLT2. So increased reabsorption occurs, ultimately leading to a decreased delivery of the sodium chloride to the DCT, which leads to increased tubuloglomerular feedback at the level of macular densa. And here there is an increase in the intraglomerular pressure. So when a SGLT2 inhibition is given to these patients, so and the glycosuria, there is a blockage at the level of the SGLT2. There is increased loss of glucose in the urine, and there is increased delivery of the sodium chloride to the DCT, which leads to again a alteration or a reduction of the tubuloglomerular feedback and leading to an increase in the intraglomerular pressure. So apart from the glucosuria which occurs here, which takes care of your glycemic parameters, when there is a decrement in the renal hemodynamic parameters, the renal tubules are definitely benefited. So here is just a brief explanation of how these drugs give a benefit to the renal tubules apart from taking care of the glycemic parameters. Now here we'll take up a review about the data which we have obtained by the use of empagliflozin. So this is a phase 3 placebo-controlled trial data where the use of EMPA in comparison with other drugs as monotherapy or as an add-on at various doses, how much of benefit we are able to get in terms of HbA1c is extrapolated. And you can definitely see here that when they are used at monotherapy at a dose of 10 or 25, whatever it may be, the improvement in terms of HbA1c right from the beginning or from the baseline when the patients what they had, definitely there is a higher reduction in the HbA1c values in comparison to other drugs when they were given as an add-on. So even if monotherapy is used, then in terms of improvement in the HbA1c, definitely there is a benefit, though 10 milligram, 25 milligram achieves a more increase in terms of HbA1c, but still overall 10 and 25, they are higher in both being used as a monotherapy or as add-on with other drugs. Now, in terms of body weight changes, so again, it has been found that in comparison to the baseline body weight, there is definitely a reduction of body weight, which is quite achievable to the tune of when you look at the adjusted mean difference in comparison to the placebo, there is definitely a better benefit both in terms of the outcomes of weight parameters when the drug is used as monotherapy or as add-on with other group of drugs. So similarly, in terms of outcome of the systolic blood pressure, now in terms of systolic blood pressure also, though in monotherapy, the outcomes were not rather very much overwhelming when it was used in comparison to other drugs, but definitely the reduction in terms of the systolic blood pressure from the baseline was definitely it was better in with the use of EMPA. Now, when the data was taken from the recording of ambulatory blood pressure monitoring with the use of EMPA in patients who are having 2-DM from the baseline in comparison to that the end of 12 weeks. So definitely there was a reduction in the systolic blood pressure at the end of 12 weeks, which was not associated with tachycardia at the end of the study period. So because usually we expect there would be tachycardia when there is a sudden reduction in the blood pressure, that was not associated with increase in the heart rate. So similarly, the diastolic blood pressure also, there was a reduction at the end of the with the use of this drug, both at 10 and 25 milligram of doses after 12 week of use in comparison to the placebo. So now in terms of outcomes of the lipid parameters, when the data has been found in comparison to the lipid parameters with the use of 10 and 25 milligram of drug. Now we can see here, we can see here that definitely there has been an improvement in the reduction of the triglycerides, but the HDL cholesterol values, rather it increased in the use of these drugs in comparison to that of the placebo users. There was no much change in the LDL to HDL cholesterol ratio. And of course, there was increment in the LDL fractions and the total cholesterol fractions, which is expected to increase when the LDL increases, but the triglycerides were reduced. Now, there is a different mechanism of action in which the SGLT2 inhibitors can lead to an increment in the LDL cholesterol per se, but in the terms of achievement of the triglycerides, definitely there was a reduction of triglycerides in comparison to the baseline data. So taking an overview of the effect of SGLT2 inhibitors on glucose control, body weight, and systolic blood pressure. So use in terms of a monotherapy. So this is basically a meta-analysis data, kind of a meta-analysis data. When used as a monotherapy or as an add-on to the most commonly used group of drugs, that is metformin and sulfonylurea, just look at the terms of reduction of HbA1c, which has been quite significant. The P has always been less than 0.05 in the studies in terms of HbA1c improvement as a monotherapy or as an add-on to metformin. Similarly, in reduction of the fasting plasma glucose, definitely it has been again significant, being used either as a monotherapy or as an add-on to metformin. Improvement in the body weight, a reduction in body weight definitely, which is again significant in terms of monotherapy or as an add-on to metformin therapy, and of course reduction in the systolic blood pressure. So even as a monotherapy or as an add-on to any of the group of drugs, the outcome is definitely good. Now, in terms of determining what would be the probability of the adverse events, which is definitely important in terms of use of the drugs to a larger mass or a larger population. So this was the data which was published in 2015, where it was found that occurrence of any serious adverse effects or one or more serious adverse effects or a degree of adverse effects leading to a discontinuation of drugs, either at a 10 or 20, 10 milligram dose was definitely, it was lower in comparison to the placebo users, and at a 25 milligram dose, though the relative numbers were high, but in terms of percentage outcome, the adverse effects were definitely lesser. So if you look into the percentage values, so the occurrence of adverse effects is lower in terms of the placebo users and does not lead to a discontinuation of drugs in long term. Now, there was a risk of occurrence of increased genital infections and urosepsis with SGLT2 inhibitors, which was that the risk does exist. So, but this was a data which was again the same data which was published in 2015, which looked into the occurrence of urinary tract infections, pyelonephritis acute, urosepsis, genital infections, volume depletions. So now when we look into the data, of course, the occurrence of urinary tract infections is increased in both the male and the female sex in comparison to the placebo users. But look into the other serious complications like pyelonephritis, or significant urosepsis. Definitely, this is not very high in comparison to placebo users, but the genital infection risk is definitely higher in comparison to the placebo users in both the male and the female sex. Now, in terms of occurrence of volume depletion, again, which the risk which did exist theoretically, but on long term, it was found that in comparison to the placebo users, the occurrence of volume depletion is not significant in those who take empagliflozin. So the ultimately is what is the beneficial effect of SGLT2 inhibitors that may complement and improve the effects of mainstay of heart failure medication. So what we talked about is the changes in the parameters of the glycemic benefits, the renal benefits, and now coming to the cardiac benefits. So this data rather became more interesting after the results, the trials of the Emperor, which has been published this year, which has come up. So in terms of the heart failure medication treatments, so where we need a drug which will lead to increased natriuresis, cause improvement in the preload, afterload, LV wall stress, interstitial edema decrement, and improvement in the cardiorenal physiology. So SGLT2 inhibitor group of drugs cater to all the benefits which can be achieved, which were rather not being achieved by the conventional treatment that was given to heart failure patients, that is the ACE, ARBs, or the mineralocorticoid receptor blockers, or the diuretics, or the beta blockers if they are not into NIHA 3 or 4. So SGLT2 inhibitor is a drug which is rather having physiological action on every part and can give a benefit to patients who have got heart failure per se, be it a diabetic or a non-diabetic. Non-diabetic part came up after the results of Emperor trial. So I'll be discussing about the major outcomes which has been found with this landmark trial, that was the EMPA-REG trial. So in terms of the primary outcome included the 3-point MACE, and if we're looking into the individual components of 3-point MACE, either CV death or the non-fatal MI or the non-fatal stroke. So overall, there was the hazards of occurrence of 3-point MACE was 0.86, and definitely it was statistically significant. Now going into the individual components, CV death and non-fatal MI, though there was reduction, but statistical benefit was obtained in terms of CV death, where the hazards was 0.62, which was significant. Non-fatal MI, though the hazards was 0.878, it was not statistically significant. And as a single component looked into non-fatal stroke, though the hazards was more than 1, again, it was not statistically significant. So definitely EMPA-REG has given us enough idea that use of EMPA definitely gives us benefit in terms of outcomes, in terms of the CV death. So coming to the secondary outcome, which was found in terms of the renal outcomes from the EMPA-REG trial. So here the occurrence of incident or worsening nephropathy in the drug users was definitely less in comparison to the placebo users, with the hazards being 0.6. The progression of microalbuminuria, again, the drug users, they were benefited, and the hazards was 0.62. And though the composite renal outcome, when you compare the EMPA and placebo users as the secondary analysis of this trial, so definitely the composite renal outcome was much better in the drug users in comparison to the placebo users. So apart from the cardiac findings and the renal findings which were found from the trial, it was also found that in patients with T2DM and high CV risk, EMPA given in addition to standard of care reduced heart failure, hospitalization, or CV death, with a consistent benefit observed in both those who had or did not have heart failure at the baseline. So irrespective of occurrence of heart failure before or presence or absence of heart failure, definitely there was benefit to all the patients who were taking the drug. Now, next question arose that how early after the treatment initiation are the CV benefits of EMPA visible or rather apparent, which was a post hoc analysis of the EMPA-REG outcome. Now, the EMPA-REG outcome trial showed that CV benefits occurred quite early rather than the achievement of the glycemic parameters. Before the glycemic parameters were attained, the CV benefits were seen quite earlier. So, exploration at what time point since the randomization, they became quite apparent from this analysis, and the hazard ratio, they stabilized as the number of patients with events increased over time. And it was found that benefit of EMPA in reducing the risk of hospitalization due to heart failure, CV death or hospitalization due to heart failure, and CV death emerged within quickly weeks, as quickly as 10 to 12 weeks after initiation of treatment in the EMPA-REG outcome landmark trial. So, reduction in risk with EMPA versus placebo reached significance as quickly as day 7 for hospitalization due to heart failure and day 27 for CV death, and sustained significant throughout the follow-up. So, this was the earliest one, but majority of the patients, their improvement was formed as early as around 6 weeks to 8 weeks. So, benefit on CV death reached significant for the first time at day 59 or at the end of around 3 months. So, earliest effects appear to be on the hospitalization due to heart failure, and time to benefit for hospitalization due to heart failure in the drug users was as quick as it has been quoted here. It was as quick as around 15 to 17 days. And time to benefit from hospitalization due to heart failure or CV death was as quick as 3 months of taking the drug therapy. So, moving on next to the comparison of the currently available SGLT2 inhibitors. Now, one more drug has also come up, the Empagliflozin, which I have not included because as of yet, lone landmark studies has been approved and it is only being used in India, not yet approved by majority of the guideline forming authorities. So when we compare these drugs, the dose is highest with canagliflozin, and both EMPA and DAPA can be used with or without food, and it is a single dose. Now, the plasma maximum concentration is achieved earliest rather with EMPA within 1 to 1.5 hours, and Kana takes a time to around 1 to 2 hours. Bioavailability highest is with dapagliflozin, but not bad with EMPA, which is more than or equal to 60%. Metabolism is primarily through the hepatic mechanism and no active metabolites are present. But in comparison to the elimination, when we look at the hepatic and the renal part, so definitely in comparison to DAPA, the elimination half-life is higher with EMPA users and the highest with Kana users. So it's quite, in comparison to DAPA, which is currently available use is on a high rise since the loss of the patency, the elimination half-life is higher, and selectivity over SGLT1 is 1:5,000. Now, SGLT1, where it is present at the level of guts, intestinal mucosa, and its role is again on glucose reabsorption. So, selectivity over SGLT1 is rather highest. I mean, the ratio is 1:5,000 with EMPA users. And glucose excretion in amongst all the three drugs, it comes second in line. Highest is with Kana users. So CV safety trials have come up since 2008, where US FDA told that CVOTs must be done, and since then CVOTs have come up, and then we have got CVOTs with Kana, the Canvas, and the Canvas R, the Credence, and with EMPA, EMPA-REG, and with DAPA, it was the declared TIMI, and so on and so forth. And we are expecting late the Empagliflozin outcomes, which will be coming up in 2021. So apart from these were the CVOTs. Further, again, landmark studies with EMPA in terms of EMPA-Heart, EMPRISE, and EMPEROR have come up, which will be taken up by Dr. Dipak. So, metformin initially 2012, when ADA gave that guidelines, only one drug, the first line, still now it is metformin. So after 3 months, if the HbA1c is not achieved, then any other group of drug to manage the glycemic parameters depending upon the characteristic features of the drug were to be decided. But now, since the CVOTs have come up, so, and depending upon the presence or absence of ACVD or CKD, if the HbA1c is not attained, so the switch on and the add-on, definitely it goes off with the SGLT2 inhibitors or a GLP receptor analog, which has got CBCB benefit. So since the CVOTs, the ADA has also revised the guidelines, and of course, the first line therapy is metformin. And if there are indicators of high risk or established ACVD, CKD, or heart failure, and if ACVD predominates, preferably SGLT2 inhibitor or GLP-1 receptor analog who has got proven CVD benefit. And if heart failure or CKD predominates and your HbA1c is not achieved after giving monotherapy with metformin, so preferably add on to a SGLT2 inhibitor with evidence of reducing the occurrence of heart failure or CKD progression. So this has come up, and the other arm, here it is not that beneficial to talk about. So we are basically talking about if ACVD or heart failure or CKD predominates and we are not being able to achieve the glycemic parameters. So just to summarize, diabetic patients, there is an overlap of all the cardiac, renal, and the metabolic parameters. And we need to choose an ideal drug which is going to give benefit to our patients by targeting everything. So individualize your patient, what they have, what they do not have, and then they decide the drug therapy, because ultimately you want to give them increased survival with reduction in the morbidity. So the current place of EMPA in the management of T2DM, and since the evidence of these CVOTs, they have definitely shown benefit in terms of MACE with SGLT2 inhibitors. Both EMPA and CANA have got shown benefit. So EMPA we are talking up. So EMPA, their use must be rather, I would like to say, generalized and should be used to the larger population who are going to get benefit by the use of this drug. So CV mortality benefit extends across the entire spectrum of CVD occurrence, not only CAD, but also PAD, isolated MI, or stroke. So ADESSD consensus report recommends preferential use of agents with label indications of reducing CV events in patients of T2DM with compelling need for CVD risk reduction, either as an add-on to metformin or if HbA1c at target with dual therapy is not being achieved. So optimize clinical considerations of risk-benefit of anti-diabetic agent in principles of individualized approach, which is very important. But everything has got a disadvantage also. So be careful when you're using SGLT2 inhibitors in those patients who have got complicated UTIs, in women who have got urinary incontinence, or men having prostatic hypertrophy, who have pre-existing hypovolemia or having borderline renal functions, or are on along with multiple polypharmacy with the use of diuretics and NSAIDs. And if in a hypovolemic or in a hypotensive individuals, these group of drugs are used, then they should be carefully monitored with along with the fluid parameters of the patient. And one more thing, necrotizing fasciitis of the perineum is, if any at all, if your patient he had or he has, so then the US FDA says that this is a black box warning for the use of EMPA in these group of patients. So thank you very much for your patient hearing. I would now stop sharing my screen and I would hand over the session to Dr. Souvik to carry forward. Thank you very much.
Dr. Ipsita, thank you very much. Dr. Dipak, you can start the presentation, please. Because we're running short of time. Thank you. Yeah.
Are my slides visible now?
Sir, it's visible.
Yes, sir, it's visible. Sir.
Yeah,
Yes.
thank you.
So Dr. Ipsita has lucidly described and highlighted the key aspects of the endocrine-related benefits of an SGLT2 inhibitor and specifically empagliflozin. My job is to highlight the cardiologist perspective, or what sort of a cardiac benefit a patient is likely to derive once he is on an SGLT2 inhibitor and specifically empagliflozin. At the outset, let me tell you, there have been so many studies on anti-diabetic drugs, but EMPA-REG outcomes should be considered as a watershed mark. Why? Because prior to EMPA-REG outcome, none of the trials have ever shown the cardiovascular mortality benefits. All of them had showed mortality neutral. That means there is no adverse effect on cardiovascular mortality. But the first time in the history of anti-diabetic medications, in EMPA-REG outcome, a positive benefit so far as the cardiovascular mortality endpoints come out. And that's why it's a landmark trial. And the important points of the trial have been clearly highlighted by Dr. Ipsita. Now, when we think of SGLT2 inhibitors, the three important aspects, besides their blood sugar reducing benefits, are hospitalization due to heart failure, then cardiovascular death, and the renal related outcomes or the kidney related outcomes. And the three SGLT2 inhibitors which have large scale evidence in favor of them already existing are, of course, empagliflozin, canagliflozin in CANVAS program and CANVAS-R, and the dapagliflozin. So, and when we think of all these aspects, we find they have had robust benefits, both in terms of hospitalization to heart failure, CV death, as well as renal endpoints. And amongst all the trials, if we give a specific importance to EMPA-REG outcome, which is, of course, the watershed mark, what we see is there is an early benefit which is accrued to the patients who are on empagliflozin, and this benefit we cannot simply explain by their capacity to bring down the blood sugar level, because by reducing blood sugar level, this extent of benefit in terms of cardiovascular mortality reduction is simply unthinkable, because as it was very clearly highlighted by Dr. Ipsita, by the end of even 4 to 6 weeks, you start to get the benefit, which you'll see as the curves start to diverge. But whenever we think of the heart-related benefits or the cardiovascular benefits, which of this benefit is more important for the patient? Because when we look at the Framingham Heart Study, which is, so to say, the pioneer of a concept of providing cardiovascular prevention, the overall, if we look at the reduction in total cardiovascular death or the cardiovascular events or cardiovascular failure or the peripheral arterial endpoints like intermittent claudication or stroke, the single most important driving factor was cardiac failure. So heart failure related benefits, both in primary outcome or secondary outcome, are a very key factor when we think of utilizing these drugs for a large scale patient population and deriving its benefits. And in contrast to the general perception of what are the number of events that a drug has been able to bring down in terms of reducing acute coronary event, commonly known as myocardial infarction, between these two outcomes, if we consider the multiple trials like LIFE, renal IDNT, means these are trials, multiple trials, where it has been seen that heart failure is a more common outcome than myocardial infarction in diabetic subset of patients. And the extent of heart failure related benefits may not go hand in hand with the myocardial infarction related benefits that you derive from a molecule. And when we look at this forest curve from the meta-analysis of multiple trials, we find that ACCORD is a very peculiar trial where you are able to achieve a better glycemic endpoint, but at the cost of serious or deadly cardiovascular endpoints, which increased. That's why people commonly say that the trial name was ACCORD, but it had a discard. So, heart failure outcome trials in glucose lowering agent in patients with diabetes, if we look at the different trials and we would like to get an impression about the maximum extent of benefit, then you find that the maximum deviation from this baseline to the downslide is from the EMPA-REG or the SGLT2 inhibitor related studies. In EMPA-REG, of course, the two doses were tried, that is Empagliflozin 10 milligram and Empagliflozin 25 milligram. And the important endpoints, the 3-point measure of CV death, non-fatal myocardial infarction, and non-fatal stroke, all of them showed benefit. But what I would like to highlight is you just see both the curves. You look at the curve in the red mark and the curve in the gray mark, and you find both the curves started to diverge quite early. That means the extent of benefit that a patient is going to get after utilizing empagliflozin for its treatment, it's exclusively not because of reducing the blood sugar, because of the other benefits. And when we think of that, the SGLT2 inhibitor affect multiple pathophysiological aspects of heart failure. And if we cut across the SGLT2 inhibitor trials and 3 landmark trials of empagliflozin, canagliflozin, and dapagliflozin, we find that one type of benefit has been uniform across any SGLT2 inhibitor, and that is HHF, or hospitalization due to heart failure. Some of the endpoints, let's say the coronary artery disease related endpoints, have not been that robust, statistically robust in canagliflozin as we compare to empagliflozin. But one endpoints have been definitely significant, that is hospitalization due to heart failure. And that is why the current concept is to use them not as anti-diabetic agents. Of course, they will be used as anti-diabetic agents in treatment of diabetes, but to use them as exclusive treatment for heart failure. And of course, heart failure with reduced ejection fraction, about which we have robust data. Now, the multiple pathophysiological benefits, we know it increases the urinary volume, so thereby obviously it will cause natriuresis or loss of sodium, and we know it's going to provide benefit. And it improves the kidney function, and we know in heart failure the improvement of kidney function can give definite benefit to a heart failure patient, and its decline can also accordingly bring down the heart failure status. And we know the different CRS or cardiorenal syndromes are situations when both the heart and the kidney start to decline their function. And what is important is these drugs reduce the interstitial edema. That's why currently they are being termed as smart diuretics. Means diuretics reduce the intravascular blood volume, but these drugs bring down the interstitial blood volume, which is more beneficial in a patient of heart failure. And of course, they reduce the preload and afterload. They have been shown to bring down the systolic as well as the diastolic blood pressure. When we think of heart failure treatment, basically all the therapies can be divided into 3 different classes of agents. there are therapies which can actually prevent heart failure. Means there will be a subset for development of heart failure. In them, if we use these class of agents, then maybe in days ahead, the chance of developing heart failure reduces. So they are mainly preventive. So suppose a person has coronary artery disease, use statin, then consequently his event rates decline and subsequently his heart failure decline. If you are using drugs for adequate blood pressure control, thereby you are also reducing heart failure. Of course, this could be heart failure with preserved ejection fraction. Then the SGLT2 inhibitors to prevent heart failure. Then there are different drugs. Then there are therapies which have been proven to be benefit in established heart failure patients, like the drug ARNI, or the heart rate reducing, exclusive heart rate reducing agent like ivabradine, or devices like CRT, ICD, or mineralocorticoid receptor antagonists. Then there are therapies which have benefit in terms of preventing heart failure and also providing mortality and morbidity benefit in patients of already existing heart failure. And they are the class of agents like beta blocker, ACE inhibitor, ARB, and exercise. And with this background overview, we'll try to focus on a trial that is Emperor and exclusively on heart failure. Now, let us not forget that the similar sort of outcome have come with other SGLT2 inhibitors. So you actually include, this was presented in European Association for Study of Diabetes virtual meeting. So you include patients who not only have heart failure with preserved ejection fraction, but heart failure with reduced ejection fraction. Currently, heart failure is divided into 3 regions based on echocardiographic criteria. If the ejection fraction is more than 50%, they are heart failure with preserved ejection fraction. If it is less than 40%, that's heart failure with reduced ejection fraction. And between 40 to 49% is considered heart failure with mid-range ejection fraction. But for this study criteria, they have taken people with less than 40% ejection fraction as heart failure with reduced ejection fraction, and people with more than 40% as ejection fraction as heart failure with preserved ejection fraction. And when you look at what are the different places from where they have, it's actually truly a global study, because we have patient population from North America, South America, Australia, Asia, Europe, Africa, so all across the globe. So it can be considered as a truly global study, including people of all sorts of ethnicities and races. And what you find here is this has already got a publication in European Journal of Heart Failure way back in 2019. So in contrast to Empiric outcome, where 2 doses of empagliflozin were studied, that is 10 milligram and 25 milligram, this study took up only 1 dose, that is empagliflozin 10 milligram daily. And they tried to assess the different benefits, and the primary endpoint was time to first event of adjudicated cardiovascular death or adjudicated hospitalization for heart failure. Now, the key importance was given to CV death and heart failure related hospitalization. And we must not forget that in contrast to India, the so-called advanced European countries or in America, the 1 episode of hospitalization is quite costly. And if you have repeated episodes of hospitalization, that can actually devastate your financial condition. So the SGLT2 inhibitors are the future of heart failure treatment, because heart failure therapies were, so to say, at a dead end so far as the drugs are considered, because none of the new drugs came. Then after quite a substantial period of time, first time ARNI came up, And now the SGLT2 inhibitors are the newest kids on the block, which have shown to have not just mortality, but morbidity benefit as well. And what are the speculated mechanisms? Because they reduce the cardiac preload, that's obvious, but they shift to ketone metabolism, that is a more effective myocardial metabolism as compared to utilizing sugar. They have adaptive cellular reprogramming and inhibition of sodium hydrogen exchange. So that has been one key aspect of heart failure therapy. They have been shown to have improved endothelial function and reduced cardiac fibrosis. Now, this last point is also suggested as one of the proposed mechanisms by which they could be important in treatment of heart failure with preserved ejection fraction as well. So the publication in NEJM, that was in August 2020. Now, there have been a lot of discussions on their outcome in European Society of Cardiology. In fact, if you compare the sort of the extent of discussion in cardiology forum versus endocrinology forum, they'll be at par. So the time is gone when people used to think that SGLT2 inhibitors are novel anti-diabetic agents. Now they are a novel heart failure agent as well. And they have definitely significant data when we think of heart failure with reduced ejection fraction. And Emperor reduced, they had three specific endpoints. First is the composite of cardiovascular death or heart failure hospitalization. There are two secondary endpoints. First is the time to first or recurrent heart failure hospitalization, and second is a decline of glomerular filtration rate. So you get an information not just about the cardiac benefits, but of course regarding the renal benefits. And we know that many a times in heart failure patients, these two benefits are interlinked. So the goal of trial was to assess safety and efficacy with symptomatic heart failure patients with reduced ejection fraction. And more important is irrespective of the diabetes status. That means a substantial proportion of patients did not have diabetes. So it's actually a great shift from the way people used to think about drugs, because we know after ACCORD, people knew that in high-risk patient subsets, if you bring down the blood sugar, you very drastically, you have a likelihood of increasing the CV mortality. And with that background, this trial has showed that in non-diabetic heart failure patients, if you are using a drug that was earlier used exclusively to bring down blood sugar, you still derive cardiovascular related benefits in terms of morbidity reduction, also mortality reduction. So more than 7,000 patients were enrolled, and this was the inclusion criteria. Yes, I have already suggested that the inclusion criteria in heart failure in Emperor reduced arm was LVF less than 40%. And they must have had an episode of heart failure hospitalization within last 1 year, so within 12 months. And of course, the NT-proBNP has to be really significant. So, like if your ejection fraction is more than 35%, then the level was considered to be very high, that is more than 2,500 picogram per ml. So the exclusion criteria, of course, acute coronary syndrome were excluded within 90 days. People for heart transplantation or severe valvular heart disease or with implantable cardiovascular defibrillator or CRT, ICD-CRT people within 3 months, they were excluded. And this we have already suggested. They had all sorts of patients. Patients, whites, Asians, North America, Europe, Asia, all sorts of functional class 2 was 35%, mean ejection fraction was 27%. That is highly significant because these patients are likely to be sick. And in such a sick patient, we are going to use a drug, and that we have derived benefit is something which gives a very strong message about their efficacy as heart failure. And when we look at the concomitant medications, we find that all important concomitant medications were used significantly, like beta blocker, more than 90%, MRAs more than 70%, and AS inhibitor ARB more than say 70%. So of course the ARNI was a relatively new drug, so their utility was less. But if we add the ASARBs 70% and this 20%, that comes to around 90% as well. And even devices, the ICD implantation was in 30% and CAT. So it gives a complete mixture of set of patient populations which may derive benefit from these patients. And when we think of the primary benefits, then heart failure hospitalization was very robust, the 13.2% versus 18.3%. So that is, and we see that across all endpoints, the primary endpoints, there are 25% reduction, but even the secondary endpoints, 30%, and the renal secondary endpoints reduced by 50%. And the similar sort of divergence of curves to EMPA-REG, that's sort of a deja vu feeling if you look at these curves. So you feel as if you are watching the curves of the EMPA-REG outcome. So you find that very early separation of the curves, which means the persons with heart failure and reduced ejection fraction, once given these sort of agents, tend to derive the benefits quite early. So that's actually startling, it's revealing, and it also gives us a very strong indication that they should be included. And a similar sort of curves you find in terms of cardiovascular death or hospitalization to heart failure, and composite renal events also. So it has a major implication for clinical practice. Now there is a compelling evidence they should be included in the heart failure therapies as one. So if you look at the curves, the table showing the different study outcomes, hospitalization for heart failure and death from any cause, that means not just cardiovascular, even non-cardiovascular deaths, they have been quite robust reduction, so that the effect on individual components of the primary endpoint, that is the primary composite endpoint, as well as the two secondary endpoints, hospitalization for heart failure and cardiovascular death, everything has been quite statistically significantly reduced by empagliflozin given at a dose of 10 milligram once daily. So this just reiterates the same, the extent of events, the extent of event reduction, not just the first event, but even the recurrent event reduction. So safety has been already highlighted by Dr. Ipsita so far as the different key aspects. The most important aspect is the urogenital infection or sepsis, and for cardiac endpoints, the volume depletion, hypotension or symptomatic hypertension persons whose blood pressure is at the lower range. So like most of the Indian heart failure patients, so for them this is a big issue. If you can safely use an agent without substantially bringing down the systolic blood pressure or even mean arterial pressure, then that will be of great help. So the key question, does empagliflozin lower the risk of CV death or hospitalization in patients of heart failure? Of course, the answer is yes. And irrespective of which class, a patient belongs. It is whether it is class 2, class 3, or class 4. If his ejection fraction is less than 40%, this is the data which definitely says that the patient is likely to derive benefit, and the data is from a median duration of 1.5 years. So these, when we consider the secondary outcomes, and in them the most important are renal outcomes. So renal outcomes are also very critical in patients of heart failure with reduced ejection fraction, whose ejection fraction is less than 40%, because these patients have a high risk of going to CRS or cardiorenal syndrome. And once they go into cardiorenal syndrome, all sorts of composite endpoints are on the rise, because the heart failure related endpoints, the CV death related endpoints, as well as the renal endpoints, all of them tend to rise. So if you have a benefit here, then of course the long-term benefits of the drug will be statistically significant. So overall, the empagliflozin was found to be superior to placebo in improving heart failure outcomes among patients with symptomatically stable heart failure with reduced ejection fraction, with an ejection fraction less than 40%, already on GDMT. So these patients were already on beta blocker, mineralocorticoid receptor antagonist, and ACE inhibitor ARB, which are the principal agents, and irrespective of the diabetic status. So if you have diabetes, you tend to get the benefit. If you do not have diabetes, still also the extent of benefit is quite significant. And the primary drivers are hospitalization due to heart failure reduction. So, and there is also quite a substantial contribution from a benefit of renal outcomes. So the question is it a class effect? Of course, it is not a class effect, because if you have heard about DAPA-HF trial, there also we find a similar sort of outcome. So where dapagliflozin was used, and that also in patients with ejection fraction less than 40%. So that also gave an outcome like this. So ultimately, the most important message that we get from this trial is this is a drug not just for diabetics with atherosclerotic cardiovascular disease or diabetics with heart failure hospitalization, but non-diabetics with heart failure and reduced ejection fraction with an ejection fraction less than 40%. So in 2019 ESC guidelines, if you have heart failure with diabetes, earlier concept of thinking that metformin should be the first line, that you have an option or you have a choice of even considering a SGLT2 inhibitor as a first line of therapy if you have a history of hospitalization for heart failure during last 1 year. So we expect to get a substantial change in days ahead. And in ESC 2020, there has been a snapshot which says that effect of empagliflozin versus placebo on body composition in patients with myocardial infarction and type 2 diabetes mellitus, the subgroup analysis trial. It was used as an add-on therapy, and in patients hospitalized for acute decompensated heart failure, because these are patients of acute heart failure were in fact excluded from EMPEROR heart failure studies. But the subsequent research is to utilize these molecules even in patients of heart failure who are acutely hospitalized. So that is an extension of the utility of this drug to even newer fields where it has not been tried earlier. So thank you for your patient hearing. Now, Dr. Sobik will take over.
Yeah, thank you, Dr. Dipak, Dr. Ipsita, for a wonderful presentation. There is no question till now. So my question is, actually we're running out of the time also. My question is to Dr. Dipak and Dr. Ipsita. Is there any word of caution while using SGLT2 inhibitor in cardiovascular risk factors? Okay. And for Dr. Ipsita, is there any word of caution while using SGLT2 inhibitor in diabetic patients? So Dr. Dipak, you can start.
The most important word of caution that we would like to give to anybody who now is trying to use these drugs is, we know these drugs are quite effective in producing diuresis because they reduce the total circulating blood volume. So for patients who are volume depleted, for instance, a patient of heart failure whose systolic blood pressure is around 100 millimeter of mercury, so in them one should be really careful. For instance, there could be some other patient who has heart failure with reduced ejection fraction, but his systolic blood pressure is say around 130 or 140. In that sort of patient, you should be quite confident about using this drug. But some patients whose blood pressure or systolic blood pressure is at borderline, you should be really careful. And to start with, I will not advise somebody to initiate these therapies in patients whose systolic blood pressure is on the borderline. That is a word of caution.
Thank you. Dr. Ipsita, can you unmute yourself? Yeah.
Yeah. Now, in diabetic patients per se, definitely there has benefit, but some word of cautions apart from those who are or had a past history of any complicated UTI or significant genital infections or fungal infections, especially in females in genital area, and Fournier's gangrene, which I have quoted. There are some other parameters which need to be kept in mind, like those who have ASCVD or CKD but are having a very low BMI, those who have pre-existing sarcopenia. So in these group of patients, though they have ASCVD or CKD and you want to use these drugs, you must be very careful in those who have pre-existing sarcopenia. Second is, now with CANA users, there was increased risk of amputation, which was statistically significant. Now, though we do not know, though EMPA and in DAPA users in dyslipidemia and EMPA, this was not fun, but definitely that thing must be kept in mind that those who have PAD with a pre-existing amputation, the drugs must be used carefully, be it any of the SGLT2 inhibitors. Now, and those who have got renal problems with a GFR less than 30, like until 25, DAPA CKD found that DAPA with until 25 GFR, the drug use is beneficial to the patient. So if a GFR or less than 25, so in those group of patients, the thing must be kept in mind. One more thing I would like to highlight is there are group of young diabetic patients, they present between 20 to 30 years of age. Okay, now T2DM early onset can also be seen in adolescent populations, but in 20 to 30 years of age, there can be a group of patients who are initially thought as T2DM, but they are not T2DM. They could be any autoimmune variant, which somewhat mimics like the type 1 diabetic group of patients. So when you are not very confident regarding the cause of diabetes in these group of patients, we must be careful because definitely there is increased risk of diabetic ketoacidosis in those who have got immune mediated diabetes and you use that drug. So these are some points which must be kept in mind.
Okay, thank you. So we're concluding the session. Dr. Dipak, Dr. Ipsita, thank you for a wonderful presentation and sharing your valuable experiences. And on behalf of Lupin, we thank you both and we'll see you in the future meetings. Take care in this COVID scenario. Thank you.
Thank you. Thank you all.